Welcome to the next session on FTS perspective. Our first speaker will be Dr. Michael Rothberg on combinational treatment and focal therapy.
Okay, thank you to the organizers for the opportunity to speak on what I think is a very interesting topic in terms of just the future and the potential for focal therapy. So this is combinational treatment in focal therapy. So the first thing I wanted to start off with is just sort of a review of what has been reported and what our field understands with respect to biological response to focal ablation. The three energy modalities I wanted to highlight are those that have the most evidence available that I was able to find. And so looking at cryoablation, HIFU, and IRE, there are pretty well defined and characterized local and systemic responses from an immune standpoint to each of these ablation modalities. So cryoablation, obviously the mechanism of action involves inducing hypothermia within tissue that's treated. Locally, this has been shown to induce necrosis in more central areas of treatment and apoptosis in the peripheral regions of treatment. And these findings have been shown to correlate with hypoxia and also decreased microvessel density in areas that are treated as well. The resultant cell membrane damage that occurs in this setting can lead to release of intact native tumor-associated antigens, and that's typically what's been described with respect to local response. From a systemic standpoint, cryoablation produces an immunostimulatory response with increased levels of CD4 and CD8 effector T cells, as well as decreased levels and increased fragility of immunosuppressive regulatory T cells. For HIFU, the mechanism of action of this obviously involves thermal ablation and heating tissue above a certain threshold for treatment. Locally, this will produce a coagulative necrosis as well as cell membrane disruption and protein denaturation. There have also been reported increased levels of heat shock proteins and pro-inflammatory cytokines in the local tumor microenvironment of treated areas. An important distinction, though, is that while hyperthermic ablation modalities are associated with release of these tumor-associated antigens, there are several reports that suggest that the proteins that are released in the setting of hyperthermic ablation are often denatured because of the heat exposure and may not yield as specific of a tumor-specific immune response as a result of that. IRE, this is a non-thermal mechanism of action whereby electrical pulses are transmitted, producing irreversible nanopores in cell membranes, and this results in apoptosis due to cells not being able to maintain homeostasis. Treat-resect study that was published a few years ago for patients who were treated and then underwent radical prostatectomy 4 weeks following their IRE treatment showed both areas of fibrosis and necrosis, as well as an inflammatory infiltrate that was seen on whole mound histopathology. Importantly, these studies have indicated that tissue subjected to IRE will also release a large amount of tumor-associated antigen that's not been damaged by ablation. There have been some studies, both preclinical and clinical that we'll touch on later, that show that as a result of IRE, there is systemic effector T cell activation and also reduction in regulatory T cells that are known to be immunosuppressive. So the rationale for combinational treatment, improvement in rates of infield or margin recurrence, areas that are just not treated quite enough at the margin, the potential to combine device with additional medications to try and have successful treatment in those areas, release of tumor-associated antigens and subsequent systemic immune response, and then theoretically, sort of the holy grail, this concept of an abscopal effect, not only locally, but local regionally and distally as well. The first study that I wanted to talk about, this was a study that was published in 2008. This was a study out of Japan, 530 patients. 270 underwent HIFU with no more than 6 months of neoadjuvant ADT. The remaining 260 underwent HIFU without any neoadjuvant ADT. They defined disease-free survival based on serial PSA measurements following treatment and the Phoenix criteria. They performed biopsies at 6 to 12 months following treatment. And they report that neoadjuvant ADT was associated with improved 3-year disease-free survival in both intermediate and high-risk patient groups without a significant difference being noted in the low-risk patient population. This is a prospective randomized trial that was published in 2021. It's 20 patients who underwent prostate cryoablation with or without GM-CSF, with the objective of determining the impact of administration of GM-CSF on development of T cell and B cell responses against tumor-associated antigens, and the results are shown on this heat map here. The take-home message: at 4 weeks after cryotherapy, the treatment group demonstrated an average fold change in cancer antigen-related antibodies of 2.8% above their baseline values, while controls was about 18% change below their mean baseline. At 12 weeks, this was potentiated even more to 25% above baseline for those who received GM-CSF, 9-fold, average fold, below baseline for controls. This is a study that was published in 2020. It's a pilot trial of pembrolizumab with ADT plus prostate cryotherapy for men who are newly diagnosed with oligometastatic hormone-sensitive prostate cancer. And so this was done out of Johns Hopkins. 12 patients with newly diagnosed disease underwent treatment with ADT for no longer than 8 months, pembrolizumab for 6 doses, followed by whole gland cryoablation. Their primary outcome here was the number of patients with PSAs below 0.6 at the 1-year time point, where they would have expected testosterone levels to recover following ADT. 5 of 12 patients met this primary outcome. Their PSA response was defined as a decrease greater than 50% from baseline was achieved in 11 of 12 patients, that's shown on the first plot there. The median PSA progression-free survival was about 61 weeks. The median systemic therapy-free survival was 76 weeks, and their median metastatic castrate-resistant prostate cancer-free survival was not yet reached at the time of publication. Repeat biopsy was performed at least 4 months following ablation. In 11 of 12 patients, 9 showed no evidence of disease, 2 had residual disease, 1 of those was grade group 1 disease. And so overall, this regimen was well tolerated with only grade 1 and 2 AEs reported, and there were no complications related to cryoablation. This was a study that's presented earlier today, but is relevant to this talk as well. This is the IRE immuno study, whereby patients with intermediate risk disease, grade group 2 or 3, and a PSA less than 20 underwent either IRE or radical prostatectomy. 20 patients underwent IRE, and blood was collected at baseline, and then at 5, 14, and 30 days post-treatment. Patients who underwent IRE also had transperineal template mapping biopsies at 12 months following treatment. And the major results that are shown here is that patients who were treated with IRE showed significant upregulation of CTLA-4 on both CD4 and CD8 T cells, most pronounced at 14 days after treatment. And you can see the differences in the charts here between those who were treated with IRE on the left side and those who were treated with prostatectomy as a control on the right side. And CTLA-4 expression levels on these CD4 cells were significantly higher after IRE compared to those who were observed, what was observed in patients who underwent radical prostatectomy. Additionally, in addition to reporting on effector T cells, the authors also report on immunosuppressive regulatory T cells. There were significant decreases in the frequencies of regulatory T cells shortly after IRE, peaking at 14 days, and this effect was seen lasting up to 30 days after treatment. Both activated and resting regulatory T cell subsets were independently downregulated, and shows the importance of not only are the numbers of these regulatory T cells in lower frequencies, but the active immunosuppressive regulatory T cells, those are decreased in number as well. So since this is an evolving field, I did want to touch on some ongoing clinical trials that are relevant to this talk in sort of the combinational space. This one is a trial that's out of Cornell. It's radiation therapy plus IRE for intermediate risk prostate cancer. They are looking to enroll 42 patients with either grade group 2 or 3 prostate cancer on targeted biopsy, with the primary outcome being feasibility of combining IRE plus SBRT for management of this cancer. Secondary outcomes being presence of prostate cancer in treated fields at 12 months after treatment on biopsy, plus some health-related quality of life questionnaires as well. The second trial is one that's been mentioned many times throughout the meeting here, is the Kronos trial, but specifically the Kronos B arm of this trial. This is out of the UK at Imperial College. There's the pilot study, which has already been recruited and enrolled for. The data was actually presented and won a Best Abstract here at the FTS meeting. They're now in the process of recruiting the remaining 1,260 patients for the rest of this study. It's a multi-arm, multi-stage, randomized controlled trial of focal therapy alone versus focal therapy plus neoadjuvant finasteride or bicalutamide. These are for patients with grade group 2 or 3 disease on biopsy obtained after imaging, with the primary outcome being failure-free survival at 5 years. The last study to mention is this ENHANCE trial out of France. This is 20 patients with unilateral grade group 2 disease on MR-targeted visible lesion biopsy. It's a single-arm trial whereby patients will receive 3 months of ADT within 1 month of HIFU treatment, with the primary outcome being treatment failure, meaning a pattern of Gleason 4 or a score of Gleason 7 or greater at the 12-month biopsy, and secondary outcomes are functional urinary and sexual erectile function outcomes. So the take-home message is that this is an evolving field. There's some very interesting stuff that's been presented so far and available in the literature, and so I look forward to seeing the results of these trials and the further evidence to come in the future. Thank you.
Thank you. Can you introduce the next?
Introduce the next speakers, speaking about optimal candidates for repeat focal therapy and outcomes, Dr. Tan.